Okay, we are good to go.
All right. I guess I'll give it to one more minute. All right. So, good morning, everybody. Thank you for attending this virtual meeting or virtual lecture, case reviews for September. And everyone can see the screen, okay? Hear me okay? I'm assuming
Yep.
so. Great.
Yep.
So, as always, this is confidential and privileged information. Do not share it, distribute, or copy it in any way. And by attending this lecture, you are implying that you consent to those parameters. So, moving on to case one. I think we have some interesting cases. I always think we have interesting cases, but anyways, 22-year-old female. EMS was called for abdominal pain and a syncopal episode. PPE usage was appropriate for the situation. She was found to be awake. She had an open airway that she was protecting. They noted that she was pale, cool, and diaphoretic, but there was no signs of active bleeding. Her initial vital signs, I don't have from the time of on scene to vitals because this was a particular agency that doesn't record all those details. But, anyways, heart rate of 96, blood pressure of 113/78, respiratory rate of 16, normal room air sats, afebrile, and a normal blood glucose. The past medical history that she provided was that she was G3, so this would be her third pregnancy. She has two children at home, no miscarriages, and no previous ectopics reported. And that 12 hours prior to EMS arrival, she started to have abdominal pain. She reports nausea, vomiting, and diarrhea, no blood in any of them, including her stools. Her pain was sharp and non radiating and severe as a 9 out of 10. She had taken a home pregnancy test previously, and that was positive, and she thought that she was approximately 3 weeks along based off of LMP. And that she also reported that she just completed some antibiotics for dental surgery. So after arrival, vital signs that were just reported to you were obtained, and an IV was established. The documentation in the EMS chart stated that she had referred pain in all quadrants. There was no mass or pulsatility noted, and that she had severe guarding in her left lower quadrant. They monitor every 5 minutes for signs of shock. They left the scene at 46 minutes and recorded another set of vital signs, noting that she's now tachycardic. Her blood pressure had gone up a little bit to 120/74, and otherwise the rest of her vital signs were as previously obtained and resulted. En route, she got 700 cc's of IV fluids, and she arrived at the hospital a little over an hour. And just reviewing the pre-hospital side of things, I thought that their assessment, their physical exam, and their documentation was pretty detailed, presenting information that was pertinent. They did serial vital signs, established an IV, gave her IV fluids, and that they clearly documented in their narrative that they were worried about a possible ectopic pregnancy, and that was indicated as mentioned in their documentation. Where I think that we could improve is that her scene time or their scene time was 46 minutes. Um, Reports of syncopal episode, no 12 lead, and then consideration of a second IV if you're worried about an ectopic pregnancy based off of your clinical index of suspicion and your physical exam, as well as notifying the hospital, whatever that might look like. I think that in our system, we're probably relegated to just doing code 3 or code 1. In other systems, they might be able to say code 1 with a notification or an activation, that not necessarily that they need to go emergently with lights and sirens, but to let the hospital know that you're worried about this patient. But either way, they came code 1. The patient was roomed in at Peace Health in the blue part of the emergency room, kind of down the hallway back corner. Uh, I was the doctor taking care of this patient. Uh, probably about 15 minutes after patient arrival, the nurse came and told me that we had a new patient. They obtained those vital signs at 12 minutes. So afebrile, non-tachycardic, kind of a low normal blood pressure of 108/77 and a little tachypnic at 22. After I evaluated and got the history from her, I was concerned about her physical exam, so I grabbed an ultrasound and looked at her right upper quadrant, which is not her picture here on the right, but is a picture of what I saw. So the area that you're looking at is labeled liver, kidney, and the free fluid. So the area that we look at, or at least that we're taught in the hospital setting, is to look at the right upper quadrant at the hepatorenal juncture and look at Morrison's pouch, because that is the most sensitive spot for identifying any intra-abdominal free fluid. Upwards of 200 cc's of fluid can be detected on this view. She had a positive FAST, and given her lack of liver disease and her presenting history, the concern was that she had blood in her abdomen. So she OB was consulted at 22 minutes before any labs or any other results besides the physical exam history and the ultrasound at bedside. So we were waiting to hear back from OB, and at 31 minutes after she arrived, a kind of an alert or a code was called to her room. While the nurse was taking care of her, she became acutely altered, hypotensive, and tachycardic. Her heart rate was 135, her blood pressure was 85/69, and she was placed on a non-rebreather mask. She was diaphoretic. Given our concern for possible ectopic ruptured and this change in her presentation, she was given uncrossed blood as well as TXA. OB was called again, and they came to bedside. They took her to the OR within an hour and a half of her arrival. When she went to the operating room, she was found to have a large hemoperitoneum, over a liter of free fluid in her abdomen. They evacuated the blood. They noted that her left fallopian tube looked dilated and concerned for an ectopic. So they removed her left ovary, or her left fallopian tube. She did not receive any additional blood besides the blood in the emergency room. She did well and was able to be discharged on hospital day 2. Any questions about this case before moving forward into a little discussion? So I thought this was a good opportunity to talk a little bit about pregnancy, since we typically see either early miscarriages that are not ectopics, or we see normal pregnancy courses if we do interact with these patients in their course. So acute abdominal pain in pregnancy, it's defined as any serious acute intra-abdominal condition accompanied with pain, tenderness, or muscular rigidity where you think that surgery might be indicated. And some of the physiologic changes in pregnancy, the uterus doesn't really become an intra-abdominal organ until she's about 12 weeks along. Initially, the uterus weighs approximately 70 grams, but in a pregnant female, it can get up to 1,110 grams at its full course of pregnancy. At 20 weeks, you should be able to feel the uterus above the umbilicus, and at 36 weeks, the uterus should extend just below the costal margin. At 36 weeks, in addition to the location of the uterus, you will also see that it's so large that it often displaces other organs. It'll displace the bowels superiorly and anteriorly, in that it can even potentially displace the appendix to be located in the right upper quadrant, making abdominal pain in a late gravid female very difficult to determine. As the uterus is further along in the 4th trimester, it can displace the omentum, causing the omentum to not be able to wall off infections very well. And it also can affect your ability to determine if there's any peritoneal findings as the abdominal wall muscles are stretched out, and it can impede the assessment of guarding. This picture on the right side of the screen that you're looking at kind of shows you the quadrants of the abdomen as the uterus would be displacing the organs. Most of them stay in there, but as you can tell that, like I mentioned earlier, that late in pregnancy, you might find the appendix in the right upper quadrant. In that, although it doesn't necessarily mean it has to, it could still be in the right lower quadrant as a non-gravid female would potentially have. But yeah. And some of the physiologic changes in pregnancy, this is more as you go further along, in this woman that we presented here was just first trimester, but the physiologic changes are often hormone induced, specifically with progesterone, and it can affect almost pretty much all of the organ systems. As a woman goes further on in pregnancy, there'll be more changes in her GI transit times. There could be delayed gastric emptying. There could be increased transit time through her bowels. There could also be increased incidence of GERD, nausea, vomiting, and then late trimester, like in third trimester, there can be constipation related to compression on the bowels, as well as increased water and salt absorption from the intestines. One of the other things that occurs in pregnant females, which should be a review for everybody, but a good reminder, is that the plasma volume increases in comparison to the red blood cell volume. So there's a physiologic anemia associated with pregnancy, especially later in pregnancy. And that means that you might have masked identification of shock state in our later pregnancy individuals. The chart or the table on the right-hand side kind of shows you what are the physiologic changes in the cardiovascular respiratory systems. So heart rate often increases upwards of 20 beats per minute. So a patient that is not infectious, in pain, or dehydrated may have persistent low-level tachycardia. Cardiac output is increased, so their blood pressures may be on the lower side, and blood volume is increased, so it might be more difficult to determine shock states given this blood volume change. And then not so much on the hematologic side for pre-hospital, but with going down to the box below, respiratory and blood gas. So tidal volume increases, so they're more likely to deoxygenate without ventilation, without an assistance. In that functional residual capacity decreases, so their respiratory rate increases, and that these patients have an increased minute ventilation, so they will oftentimes feel or report feeling that they're short of breath. So abdominal pain in first trimester, specifically like this particular patient, there are obstetric causes and non-obstetric causes. Obstetric could be miscarriage, ectopic, molar pregnancy, ovarian cysts such as torsion, hemorrhage, rupture, uterine fibroids, or round ligament pain. The ones with asterisks are life-threatening, considered acute abdomen. So any of these could be, any of the miscarriage, ectopic, or ruptured ovarian cysts can lead to potential maternal demise and fetal demise. I can tell you of a case that was non-obstetric in a young teenager who came in with abdominal pain with a concerning peritoneal abdominal exam. Sounds like similar to the one assessed on this patient in the pre-hospital setting. And although she wasn't pregnant, she had a ruptured ovarian cyst that had hemorrhaged into her abdomen, and she also had a positive fast and intra-abdominal blood. She had gone to the OR, so that can also be potential life-threatening, not just in the obstetric ones. And then non-obstetric are going to be the ones that we typically see in all of our other abdominal pain presentations. So appendicitis, cholecystitis, biliary colic, pancreatitis, peptic ulcer disease, kidney stones, bowel obstruction, urinary tract infections, and pelvic inflammatory disease. But pregnancy can also exacerbate other abdominal complaints such as GERD, increase the opportunity for pyelonephritis to occur, and it could just be musculoskeletal or bladder-related, like cystitis. So in regards to ectopic pregnancies, these are pregnancies that occur when the fetus or embryo implants in any other lining other than the endometrial lining. It's a very rare occurrence, occurring only in 1 to 2% of all pregnancies, in that if they go on to be ruptured, up to 6% of them will lead to maternal death. And if it gives you kind of a perspective, I believe that the data shows that chest pain, the acceptance or tolerance of chest pain leading to cardiac death is only acceptable under 5%, usually like 2 to 3% acceptability. So it gives you an idea of that if this is a ruptured ectopic, and a chance of 6% maternal death is pretty high, considering all the things we do for chest pain. Etiology is going to be potentially related to pelvic inflammatory disease, if they've ever had a previous ectopic, if they've had any tubal surgery, and if they are undergoing any infertility treatment. As a reminder for this particular patient, she reported none of the above regarding etiology. Signs and symptoms, these patients can be asymptomatic up until they rupture, or they could have abdominal pain. And although this is a pregnancy that doesn't occur in the uterus, 80% of them can complain of vaginal bleeding. And then there might be syncope associated with it, related to either pain or potential acute blood loss anemia. And then diagnostically, we usually get a hormone, blood hormone, HCG, ultrasound, and if they're having any bleeding in RH, to determine their RH status. And then management, depending on what type of ectopic pregnancy they have. So if there's a possibility for it to be expectant, and that means that they have a miscarriage and an ectopic that goes on to miscarriage, and that they watch them and there's no intervention. There could be the option to do medical abortion or medical termination of the pregnancy with methotrexate. But if there's any concern for rupture, that is operating room for a laparoscopic or an open evaluation and management. And then I thought it'd be another good time to talk about what heterotopic pregnancy means. And so heterotopic pregnancy, for those that haven't heard about that, is when there's two pregnancies, one pregnancy that occurs within the endometrial lining, so a normal implantation, and there's a second pregnancy that's an ectopic that occurs elsewhere. And those are patients that we try to identify in all settings, pre-hospital and hospital, where we're looking to make sure that not only are we reassured that there's an intrauterine pregnancy, but we're not missing a second pregnancy, like an ectopic, that could go on to a ruptured ectopic. And the patients that are more likely to have a heterotopic pregnancy is patients that are undergoing infertility treatment. So that's just something to keep on your radar if you're asking patients that are complaining of abdominal pain, vaginal bleeding, reports of pregnancy, to ask if there's any infertility treatment going on and currently. The image on the upper right here shows a normal pregnancy where the fertilized egg implants appropriately, and the image on the right shows a fertilized egg not in the endometrial lining, so an ectopic. And then the image below is an image during surgery, where you're seeing the uterus indicated by the blue arrows, and then you're seeing the red arrows indicating an ectopic associated with a fallopian and ovary. And then in our own protocols, when I tried to find or search ectopic, I did not see anything that came up. So I think that the most appropriate place in our protocol to review would be abdominal pain or acute abdominal pain. So as a review, we're going to be using universal patient care protocol, placing the patient in a position of comfort, identifying or recognizing shock, especially if the systolic blood pressure is less than 90, and following our appropriate shock protocols. And that because these patients are at risk of potentially needing a surgical intervention, they should be in PO, nothing to eat or drink, manage their pain, and manage their vomiting symptoms as our protocols indicate. And then I just included the pediatric abdominal pain section in that protocol as well. Consider non-accidental trauma, monitor vital signs, identify for shock, and recognize that shock numbers are different in our pediatric population. So have your references if that's your Broslow, your PD wheel, or your hand tebby, or whatever device that you use to double check your vital sign ranges. Do that for your pediatric patients. Any questions? Somebody might have one.
There's just one other clinical point about evaluating these patients. I think that's a great review. It is not uncommon for patients with ruptured ectopic and hypotension to be bradycardic, which can be confusing because most patients with hemorrhagic shock are tachycardic and hypotensive, but just don't be reassured by a relative bradycardia in patients that might be presenting with a ruptured ectopic.
That's a great point. All right. If nobody has any other questions, concerns that they want to bring up in this point, feel free to email. But moving on to case 2, 56-year-old male.
Case one about?
What's that? Oh, I think somebody is unmuted. Do you have a question? All right. So case 2, 56-year-old male complaining of chest pain. PPE usage was appropriate. The patient was found to be awake, alert, answering questions, open and protecting his airway, and that his skin was pale, cool, and diaphoretic. There were vital signs obtained by the first fire crew. Noted that his heart rate was 190, blood pressure 153/95, SATs were normal. There's no respiratory rate recorded, and that his weight was 118 kilos. His past medical history is hypertension, coronary artery disease, status post stent placement, and that he had an internal cardiac defibrillator. He had a sudden onset of chest pain 5 minutes earlier, and he stated that the pain was substernal, constant, dull, non-radiating, and worse whenever he laid down. He noted that he has not been shocked by his ICD. So the vital signs initially I just reported to you guys. Upon AMR arrival, they got a 12 lead. Actually, the 12 lead, I believe, was by fire. So this 12 lead was obtained, noted to be wide complex. There is, you can see in the upper right-hand corner that the life pack identified it as a possible STEMI involving inferior and anterior. EMS had appropriately diagnosed this as VTAC. They gave him 150 milligrams of amiodarone after an IV was established. They notified the hospital of a possible STEMI alert, and they repeated a set of vital signs, which were largely unchanged, except for his pressure was previously 150 systolic, now 130 systolic, and they repeated his 12 lead, which is here. The hospital did not upgrade this patient as a STEMI alert, as they felt that this was likely VTAC that needed to be managed before activating the cath lab. Scene time was 18 minutes, and they started en route to the hospital. He received 25 milligrams of fentanyl. Another set of vital signs were obtained. Again, heart rate of 190, but systolic blood pressure of 129. Another 25 mics of fentanyl were given, and then another 12 lead, approximately, 26 minutes after his amiodarone was given, which showed unchanged rhythm of VTAC, and then hospital arrival at 32 minutes. So just reviewing the pre-hospital side of things, identification of the rhythm, a trial of amiodarone, and IV access, as well as serial 12 leads and aspirin administration were all things that I think we did well. Where I think that we could improve is that I don't believe that this patient should necessarily have been activated as a STEMI alert, in that if he or she is not improving with the initial care, escalation of care, that's additional meds, cardioversion, and if you're not sure, online medical control. So in the emergency room, the patient had reported to the doctor that he felt similar to when his ICD had shocked him last month. Vital signs obtained at that time were similar to pre-hospital: afebrile, heart rate of 188, blood pressure of 140 over 102, normal room air sats. 12 lead was obtained, which showed the same that I had just presented to you. Additional amiodarone was given to this patient, 150 milligrams. His magnesium was noted to be low, so he was getting a magnesium replacement. And that approximately 30 to 40 minutes after his arrival, the patient started to have worsening shortness of breath, as well as diaphoresis, and required supplemental oxygen for some hypoxia. So the decision was made to synchronize cardiovert him at 100 joules, which shocked him into a sinus rhythm with resolution of all symptoms. Repeat 12 lead showed no no STEMI or ischemic changes. Cardiology was consulted. This was his third presentation since the summer for VTAC. So the cardiologist recommended that he get ablated, and that would be best done at OHSU. And the patient was transferred to OHSU. He ended up getting change in his sotalol dose. He had his ranolazine discontinued because of concern that it might be contributing to his VTAC state, and then he was started on mexiletine. They did an echocardiogram on him during his hospital admission. There was no change in his cardiac function, and then he was discharged on hospital day 4 for no recurrent VTAC. They had discharged him with plans to ablate him as an outpatient, and since this case occurred, he followed up with OHSU cardiology, and they're just going to monitor him. They're not scheduling him for an ablation yet. So in this particular case, I think we can talk a little bit about adult tachycardia as it pertains to ACLS in adult tachycardia with a pulse. So identifying a heart rate above 150, doing our kind of like basic ABCs, oxygen monitor, IV access, and 12 lead, and then identifying if this patient is symptomatic. So hypotensive, altered, signs of shock, chest pain that you feel is ischemic, or signs of heart failure. If any of those are present, the recommendation would be to synchronize cardiovert him or her. And if they aren't present, then identification if this is a wide complex rhythm. If it is wide, you can consider adenosine, but an antiarrhythmic infusion would probably be more appropriate. And if you're not sure, or as always, you always have the opportunity to consult an expert outside of yourself. And if these, so we're looking at boxes 4 and 7, depending that if those options don't work, consider the underlying cause, consider increasing the joules if you did cardiovertim the first attempt, and consider additional antiarrhythmic drugs. If nobody has any questions, I'll move on to the next slide. So looking at our protocol in regards to tachycardia that an individual might consider as stable, and moving over to the box on the right, D as in David. So wide complex tachycardia, if it's regular and monomorphic, as this one was, amiodarone is recommended, which was done at 150 milligrams over 10 minutes. If there's no conversion, the recommendation would be to repeat the amiodarone, which was not. If the wide complex tachycardia had polymorphic, then consideration for torsades should be high, and recommendations for administering magnesium. Let me see if I should mention anything else about our protocol. If you think that this might be AFib or aflutter, a rate greater than 140 and potentially with a bundle branch block, if it's falling under the wide complex tachycardia, then maybe a calcium channel blocker, but being aware that you, when you're giving a calcium channel blocker to a wide complex irregular arrhythmia, that the possibility for WPW with an aberrant conduction needs to be very present in your mindset to make sure that you're not going to have this patient degenerate to a faster rhythm that would likely degenerate to cardiac arrest. And then after treatment, get 12 leads. So I think that this particular patient had multiple 12 leads after amiodarone, potentially the possibility of giving another dose. And if this patient was felt to be unstable, pale, cool, diaphoretic, or you're seeing ischemic changes on the EKG, or you think that the chest pain is related to the arrhythmia, then you probably have enough information to support cardioverting them, considering that you're going down the unstable tachycardia algorithm. Any questions, concerns, thoughts, discussion for case 2? All right. Good to hear. So case 3 is a case of a 22-month-old male. EMS was called for breathing problems. This was a call, I believe, around 11 p.m. at night. I mentioned that because in the subsequent slides, it'll be something that is supported. PPE usage was appropriate for the situation. The primary survey was that this patient was awake. He had his airway was open. He was protecting. He had a skin exam that was pink cool with a normal cap refill. Vital signs were obtained 2 minutes after patient contact, heart rate of 160, blood pressure was not taken, respiratory rate of 30, and GCS of 14, and a room air sat of 100%. Past medical history, none reported by mom, and that the history that was obtained by mom was that the child had a cough and runny nose times 1 day. She had been treating him with Tylenol and Mucinex, and that she felt that his cough was different abruptly this evening, now barking, and that he looked short of breath to her. She had met EMS outside, I believe, outside of their ambulance when they arrived. And from 1 minute after patient contact, auscultation of breath sounds occurred, and there was auscultation of wheezes throughout. At 2 minutes, those vital signs that I just reported to you were obtained, and that he was placed on the monitor at 4 minutes. Because of the wheezes that were heard, the crew treated him with 2.5 milligrams of albuterol and also gave him 8 liters of humidified blow-by oxygen, and that they transported at 11 minutes. They transported to Randall's, which is something that was brought up in review. So at the mother's request, and because that was where his care was previously. And then another set of vital signs were obtained that were similar to the first one. At 15 minutes, he was noted to be afebrile with his temp check, and at 22 minutes, he still had wheezing. At 27 minutes, another set of vital signs were obtained, and I'm just going to go over here on the right side of the screen. So physical exam noted for increased work of breathing with accessory muscle use. They noted that he had a barking expiratory cough, the wheezing that was already documented, and mom had said that he was more lethargic than normal this evening, and that their physical exam was notable for dark circles around his eyes, runny nose, drooling, and respiratory distress with his accessory muscle use, his wheezing, and his barking cough. They arrived at the hospital at 42 minutes. So in review of care, scene time was minimal, just 11 minutes. There were serial assessments, differential diagnosis which included croup versus epiglottitis versus reactive airway disease. And then where we could improve is documentation of the vaccination status of this child, as well as any family history of asthma and consideration of using racemic epi given his presentation of the barking cough and the wheezing. So in the emergency room, they noted that he had inspiratory stridor at rest and he had significant retractions. He was treated with dexamethasone and racemic epi. His COVID was negative, and after observation of 2 hours, he was discharged home. So as we move into the fall and winter months, it's a great time to talk about a common respiratory complaint in pediatrics, which would be croup. So seasonality, fall and winter, we see about 3% of any 6-month-old to 3-year-old that will have croup, although this can be up to 6 years of age. So although it's more common in 6 months to 3 years, you can still see it at 6 years of age. And the definition of croup is any upper airway obstruction. I put in laryngotracheitis, laryngotracheobronchitis, and laryngotracheobronchopneumonitis because all of those are considered a form of the croup syndrome. So it can involve the larynx, it can involve the trachea, and it can involve the bronchi or the lower airways. And most often it's laryngotracheitis. And most often it's a viral etiology. The more deeper or lower distal involvement is more likely to be related to bacterial or atypical. Somebody has their audio not muted. And if you have a question, feel free to ask, but otherwise please mute. And the history is often that they have a URI type symptom for 12 to 72 hours prior to their presentation. They could have a low-grade fever, some rhinitis or runny nose, and that this is often presentation occurs for us in the pre-hospital and the emergency room setting in the evening. And that might be because the child's upper airway is edematous and congested with secretions, and as they lay flat or attempt to lay flat, that redundant tissue kind of relaxes and further impedes their breathing. That may be the reason for the nocturnal presentation. But either way, the signs and symptoms is that these patients will have inspiratory stridor. And because of that inspiratory stridor, their respiratory rate is often increased, as well as evidence of respiratory distress, nasal flaring, accessory muscle use, retractions, and barking cough. They sometimes will have a fever and sometimes they won't. And that if you are hearing or identifying stridor, there are other causes besides croup to be considered. So make sure that although it may look straight up like croup, that you're considering, is there a foreign body aspiration? Is there any thermal injury? Is there any caustic injury? And then moving forward with your assessment, we in the hospital oftentimes will assess a Croup score, and a common Croup score is a Wesley Croup score. So the Wesley Croup score, you can pull up ND Calc or anything on your phone, but it's looking at retractions, stridor, cyanosis, level of consciousness, and air entry. And the score goes anywhere from 2 or less for mild, 3 to 7 for moderate, and 8 to 11 for severe, and anything greater than 12 is considered impending respiratory failure. So 85% of the time, croup is going to be mild. Less than 1% of the time, they're going to meet severe criteria, and oftentimes that's going to be cyanosis, altered mental status. So if you see cyanosis or altered mental status, you should be really concerned for severe croup. And let's see here. Yeah. And then vital signs are going to be really helpful, not just for the SpO2, but looking at their respiratory rate and their heart rate. And then management for us in the hospital setting, we oftentimes use the Croup score. Oh, just kidding. I missed this. You can hear the inspiratory stridor and the expiratory barking cough. So a reminder of what croup would sound like. I'm going to play it one more time because I think that it's a good.
Very slowly.
All right, and then this is a management chart or flow chart for one particular way to manage it. So I think maybe this might change some of our own practice, but any type, mild to moderate, is always treatment with steroids. And then if they are in the moderate to severe, potentially with stridor at rest, they get nebulized epinephrine or racemic epi, and then they get oxygen if they're moderate to severe, although the evidence for humidified oxygen is only category C, so not proven to be helpful, where steroids and racemic are category A level of evidence as proven to be helpful. And if they get racemic epi, they oftentimes will be observed because racemic epi usually wears off within 2 hours. And so they want to make sure that once the racemic epi wears off, that the child doesn't go back into extremis. All right, and then epiglottitis. I want to bring this up because that was the differential for this crew and this little boy. So it's inflammation of the epiglottis or any of the surrounding structures. So the retinoids, the supraglottic area around the epiglottis. Incidence is pretty low, 3 to 5 cases in 100,000 each year. And the etiology is infectious, can be infectious or non-infectious. So of the infectious causes is bacterial, viral, although it's not the viral cause itself, it's the viral infection that sets up for a bacterial infection or fungal. And then the non-infectious causes would be like potentially caustics, thermals, or foreign body. There's a tenfold decrease of epiglottitis in pediatrics due to H influenza B vaccinations, but it's important to note that you don't necessarily have to just be a pediatric to have epiglottitis. The history that's oftentimes given is that it's usually preceded by an upper respiratory infection. The patient might have a cough, they might have a fever, and if they have a sore throat, that is 10 times more likely to be epiglottitis than for croup, for those that are trying to kind of differentiate, and helpful because we're not seeing this in little kids as much, so they hopefully can tell us that their throat is sore, and that they might be dyspneic. Signs and symptoms that we would be assessing for or potentially finding is that they might appear uncomfortable, they're toxic in appearance, they might have a muffled voice, they're oftentimes drooling, and they oftentimes complain of difficulty with swallowing. Stridor may be present, and respiratory distress may also be present. This picture of the black child in the upper right is trying to show that this child is tripoding, doesn't want to lay flat, jutting her head forward with an open mouth, and would likely be drooling. So kind of speaking to the teaching of how epiglottitis presents. And then evaluation, it's a clinical suspicion evaluation. They're not H influenza vaccinated. They are complaining of a sore throat. They are drooling. They might have some dysphagia. You have reasons to believe that you think that they might have epiglottitis. You want to put them in the position of comfort, adult or pediatric, but especially our pediatrics if we're potentially identifying these cases and early on. And then you're avoiding any oropharyngeal examination because this could lead to further swelling or spasms of the epiglottis, making a very difficult airway and respiratory arrest. Management is going to be securing the airway early and quickly and culturing the area for appropriate antibiotic coverage. And this picture, the first two, A and B, are laryngoscopy pictures of epiglottitis. The blue arrows are pointing at exudate or pus. These are all the same orientation. And then images C and D are after the patient has been intubated, treated, and reassessing those images with bronchoscopy afterwards. So you can see from the infected states A and B and the post-infection treatment, how difficult visualization would be and how the epiglottis can be quite enlarged, making it difficult to obtain an intubation. So in looking at our protocols in regards to croup, it falls under our pediatric upper airway. So first off, we look at weight, 20 to 40 kilos, and if they have audible stutter at rest, consideration of racemic epi by nebulizer mask. And it reminds me, I wanted to mention in my review of croup that croup can have wheezes, although it's oftentimes very mild, not the presenting major issue when you're listening to the pulmonary exam. So going back, you can use racemic epi. An alternative would be to aerosolize 1 to 1,000 epi. And if the child is less than 20 kilos, you'll be using a reduced dose of racemic epi or a reduced dose of nebulized epi. You're going to be treating for anaphylaxis or any foreign body obstruction if you identify that, using adult guidelines. And if the child deteriorates, you're going to be attempting to ventilate them only if the child deteriorates, knowing that this will probably be potentially very difficult to ventilate them without a definitive airway. We would be, I would say if you're thinking that your child has epiglottitis, I would be very hesitant to use an iGel on them, because that would potentially make the epiglottitis more edematous, more difficult to intubate. But these are situations I hope none of us, including our hospital providers, have to deal with very frequently. And then if you can't ventilate, you can attempt to intubate. And if they're under the age of 12 and you can't intubate, the consideration would be for needle cricothyrotomy. If they're over the age of 12, cric would be okay. Any questions? Concerns, thoughts, wishes that you don't get any epiglottitis cases?
Yeah, no, I would just emphasize, one, croup is far more common than epiglottitis. So in peds, you're basically just going to be seeing epiglottitis in unvaccinated kids. And just to underline what you said, like, these are patients that you would do everything you can to avoid having to intubate in the pre-hospital setting. These are kids that will occasionally get an awake intubation, and there's a lot we can do with racemic epi, with Heliox, other things to avoid intubating these kids. So if you think it's epiglottitis, do everything you can to avoid a pre-hospital intubation.
Yep, just like Dr. Mock says that it is far more common for croup, and yeah. All right. Anyone else have any questions before we go to case 4? All right, so case 4 is a case of a 50-year-old male who complained of dizziness. PPE usage was appropriate. Patient was awake, open airway, no cardiac or cardiovascular issues, concerns. Noted to have mild hypertension at 157/94, otherwise non-tachycardic, normal respiratory rate, and normal SpO2. Past medical history reported to EMS was that he had high cholesterol, and that the story was that this patient was at work. He was caulking at a construction site when he developed some dizziness. He drove home, but stated that it was kind of difficult to drive home. Didn't quite elaborate in the chart documentation for this. He complained of a slight left-sided headache. He was not on any blood thinners. He reported to EMS that he did not have any recent illness, any trauma, weakness, confusion, dysarthria, or blurred vision, and that his last known normal was at 11:30. He presented, I believe it was an hour and a half after onset of symptoms. He'd gone home. His significant other had persuaded him to contact 911. So an IV was established after 5 minutes, and a set of blood glucose was obtained, which was normal. A second set of vital signs were obtained, and transport was initiated 9 minutes. The documentation is that I included it here in the upper right, the BFAST, because I think that it was misdocumented. So they indicate that he did not have a loss of consciousness, which was correct. He didn't have any. They document that the patient had sudden vision changes, although there's no report anywhere else that he did have any sudden vision changes. They document that that his balance was normal and that his arm drift, speech were all normal. So I would believe that this was potentially clicking boxes too quickly because one, he didn't have any vision changes, and two, any yes would make him a stroke alert. And this patient did not come in as a stroke alert. So I'm not certain if the box clicking was accidental or if they meant to click that because he was having difficulty with driving, that there was balance problems, which would have been a yes, which would have indicated him to be a stroke alert. Moving forward, they did a couple more vital signs for him that was unchanged from the previous for the most part, and then he arrived at the hospital at 37 minutes. So blood glucose obtainment, scene time, remembering for our stroke alert cases or our concern for stroke alert, it should be within 20 minutes. They had 9 minutes on scene. They documented last known normal and obtained serial vital signs. I would also say potentially documentation of serial neuro exams would be good as well. And then where we could improve is that I don't believe that the BFAST itself was documented appropriately or accurately. And then if there's any concern for a stroke, we should be also assessing a LAMS. If any part of BFAST is positive, it's a stroke alert. So in the emergency room, the patient had a neuro exam noted to have a National Institute of Health stroke assessment of 0, so no abnormalities based off of what we evaluate for an NIH. He was complaining of dizziness and a left kind of peri or retroorbital headache, and reports that he had difficulty with walking before arrival. He does state that he's a daily smoker and that a test of skew was assessed and that was normal. His vital signs were similar to what pre-hospital had obtained, and when he presented to the hospital, we had 30 minutes left to potentially treat him with TPA. He had a delay in getting his stroke workup because he needed to be pre-medicated for contrast. So he fell out of the window for any management. His labs, his 12 lead, his CT head, his CTA head neck showed no abnormalities. He was given IV fluids, meclizine, had reported a reduction in his dizziness and no problems with his balance when he was road tested or ambulated. So he was discharged home. He had new complaints 3 days later and was called 911 again for evaluation and transport. He had told the hospital on his second presentation that although his symptoms improved, that there was a waxing and waning component to it, and that at 2 o'clock in the morning, he had acute worsening of his dizziness as well as new left facial numbness, which was improved by the time he arrived to the hospital. He was noted to have rotary nystagmus, left ear pain, jaw pain, and left cheek pressure. He had reported on his second presentation that he had recent dental surgery preceding the second presentation and the first presentation, where he had a wisdom tooth extracted and started having pain in between the first hospital presentation and the second hospital presentation. Because of all of his complaints, neurology was consulted and they recommended an MRI based off of his previous workup. And lo and behold, he had a cerebellar stroke. So I'm going to talk a little bit about cerebellar strokes. They are kind of the bane of some people's existence because of the difficulties in identifying them and trying to piece them out from peripheral causes of vertigo. So cerebellar strokes are strokes involving the posterior cranial fossa, specifically the cerebellum. of the strokes, they account for 1 to 4%, but they have a disproportionate share of morbidity and mortality. One, because it's difficult often to identify them. They're not like our middle cerebral artery strokes where we do our Cincinnati scores to identify, and because there's not a lot of room for swelling, that these ones can cause significant swelling leading to herniation, and then there's always a potential chance for hemorrhagic conversion for any stroke. So presentation is usually deficits in motor and balance, and depending on the location of the impaired blood flow, if that's the posterior cerebellar artery or the anterior or the superior cerebellar artery, they might have specific changes that would kind of help cue you into this. This particular patient had a pica distribution stroke. So those ones will present with headache, vomiting, potential vomiting, plus or minus. Usually they're going to have vertigo without an R. Vertigo, and then they'll also complain of horizontal same-sided nystagmus and then potentially truncal ataxia. Although your anterior ICA ones will have dysmetria, Horner syndrome, which is ptosis, anhidrosis, lack of sweating, and mydriasis, dilation of the pupil. They might have hearing loss on the on one side, and the same side facial paralysis or anesthesia, and loss of pain or temperature on the opposite side, where the SCA ones will be ataxia, dysarthria, nystagmus, vertigo, headache, and vomiting. Workup is the same as any other stroke, CT imaging, CT angio, MRI, and management, depending on presentation, would be just like our other strokes and potentially a higher probability of having deterioration given the small location of that fossa. So my point is, I don't want you guys to try to remember pica, ICA, and SCA distribution strokes, is to recognize the importance of using our BFAST. And that should really mean that we rule in a lot of patients for potential stroke and let the hospital determine if they want to downgrade or to not call them, continue calling them a stroke. So if we were using our protocols specifically for this patient, on that first presentation, he should have been a positive for the balance part. And that would give him a positive for B, and that would have gave him a reason to come in as a stroke alert and the document a LAM score as well. So if you think, so going to our protocol, if you think that there is intracranial bleeding, you may want to maintain normal ventilations and target an end-tidal CO2 of 35. You want to avoid hypoxia, so maintaining oxygenation sats of 94 to 98%, and frequent neuro reassessments, transport any patient who meets the following, so a positive BFAST within 24 hours, profound paralysis, aphasia, or comatose, and notify the hospital of a code 3 stroke alert. This is another point that I noticed recently in stroke alert reviews, is that some of our colleagues are calling online medical control to ask if they should come in as a stroke alert. If the patient has any symptoms that you think meet stroke criteria and you have a BFAST that's positive and it's within 24 hours, this is a stroke alert until proven otherwise. I'm not sure if we're calling online medical control to ask if we should go non-emergent, but how I've been seeing these cases is that they not only are coming non-emergent, but they're also coming as non-stroke. So if they meet BFAST criteria, you're concerned for a stroke and they're within 24 hours, even if their symptoms improve or go away upon your assessment, they're a stroke alert until proven otherwise. And then reasons for going to Peace Health is anybody with a LAM score greater than 4 or 5, or 4 or 5, and then any patient over the age of 80, any patient that's had symptoms for greater than 3 hours but less than 24 hours, you think there's a bleed, and they have any profound presentations such as paralysis, aphasia, or comatose. Any questions? All right, excellent. So lots of material covered. Thank you for your guys' attention. In review, pregnant females that have abdominal pain plus or minus vaginal bleeding and concern that they are pregnant. Lots of potential reasons for acute abdominal pain, but one of the things we worry about in emergency is anything that's life-threatening. Life-threatening is going to be ectopic, ruptured ectopic, or hemorrhagic cyst. So identifying these cases, having a high index of suspicion, and having appropriate presentation at the hospital. Secondly, if you have an arrhythmia that is treatable and you're seeing ischemic changes, treat the rhythm, especially having a low threshold of considering it unstable if you think that you're seeing ischemic changes or ischemic chest pain, not just based off of hypotension or altered mental status. Croup is going to present with stridor and barking cough. More likely to be croup than epiglottitis in our demographic of patients, and treatment is racemic. Maybe down the road someday we'll be doing steroids, and that humidified oxygen really doesn't have a lot of support in the literature, the research, but it should be really for our moderate to severe if we're going to even be using it. And then the importance of identifying BFAST on patients that might have stroke symptoms, and if they're within 24 hours of presentation, presenting to the hospital as an appropriate stroke alert. All right. Thank you guys so much for your time. If anyone has any questions, you can say them now, email me, or talk to me when you see me. Keep on doing what you're doing, and be diligent.
Excellent. Thanks, Dr. Gadbois.
Awesome. Have a great Tuesday.
Thank you.